Hi, this is Brian Warmers recording a lecture on the care of the patient with problems of the peripheral nervous system for medical surgical nursing at the University of Sioux Falls. Our learning objectives will be to describe a focal neurological assessment for a patient with peripheral nervous system disorders. We're going to identify some of the nursing priorities for patient with GBS and myasthenia gravis. We'll plan and implement some nursing and collaborative care for patients with problems of their peripheral nervous systems. We're going to identify some community resources and teaching for patients with PNS disorders, and we'll define trigeminal neuralgia. So, myasthenia gravis is an autoimmune disease that destroys the ACH receptors. So these anticholinergic receptors have antibodies that prevent the binding of ACH. So this decreases acetylcholine sensitivity, and then of course it will impact your patients. Severity can vary from mild ocular muscle weakness to rapidly developed generalized weakness. There's equal incidence between men and women. Cause is unknown, but it does seem to be related to a thymus hyperplasia. There's also a strong association between myasthenia gravis and hyperthyroidism, interferon, and bone marrow transplantation. MG is fairly rare, so the diagnosis is often missed right away, and it takes multiple hospitalizations or clinic visits to get the correct diagnosis. So this is kind of an image of what's going on here, where you're seeing your ACH and it's being blocked, and you're not getting enough transmission of this to where it needs to be. So subjective, usually this is a gradual onset. You might have some temporary weakness after like a vaccination, some menstruation, or exposure to extreme temperatures. But might have a rapid onset of fatigue as well. So patients with this can have ptosis, diplopia, and dysphagia, and with the dysphagia might have some nutritional intake and weight loss issues. Objectively, they might have ptosis or weakening of the eyelids, and this can be complete eye closure or just some weakness related to it. Tied to that, you want to assess the cranial nerves well, looking for facial expression as well as chewing and speech. And then with an advanced form, all muscles are weakened around that face. And then of course, with that, respiratory compromise is possible. Diagnostic testing can be done using cholinergic drugs such as Tensilon. You can also test for ACH receptor antibodies. We're going to check for the thyroid and the thymus and see if there's any involvement of those tissues as well. And then we can look for repetitive nerve stimulation using EMG. So that diagnostic testing, so I talked about using Tensilon before. And so what we're going to see is if they give Tensilon and the patient has an improvement in their weakness, then that will help distinguish between myasthenic crisis and cholinergic crisis, and trying to see. This is a short-acting medication, and it does not work for long-term care. Other nursing priorities with this would be impaired breathing or airway clearance, immobility, fatigue, weakness, impaired communication, and altered nutrition. Treatment of myasthenia gravis is focused on treating those symptoms and then trying to induce remission as much as possible using steroids, immunosuppressants, plasmapheresis, or even thymectomy. We do want to support them in the respiratory drive as much as possible, promote mobility as much as possible, and promote their independence with that. Drug therapy, anticholinesterases such as pyridostigmine and neostigmine can be used, but if they use too much of it, it can lead into a cholinergic crisis. Other medications might include immunosuppressants. So as we talk about myasthenic crisis versus a cholinergic crisis, they can look very similar. And so some of the ways that we're going to look at this is myasthenic is often caused by some kind of stress or infection with this one. And so that might be the cause that we're looking at. Where a cholinergic crisis is too many anticholinesterase drugs, and that causes muscle weakness. So what we can do with this one is give Tensilon like we did before, and if it deteriorates, that's more cholinergic crisis, or if it gets better, it's myasthenic crisis. Other interventions, so like I said before, plasmapheresis can be used for this. We want to encourage independence with their ADLs as much as possible, let them rest in between cares, determine their communication needs and help support them with that, monitor their diet. Eye lubricant is extremely important since we talked about ptosis and they might have some eyelid weakness. And then with the eyelid weakness, they can also get eye weakness, so patching one or both of the eyes can help with some diplopia if that's a finding of your patient. Surgical management, so the thymus might be impacted with this one, so we might remove that. If that's the case, make sure that we're giving the pyrostigmine before, trying to promote some stability, since they'll be lacking it after surgery. And then, of course, we'll be giving this on a scheduled basis to augment their lack of it. Depending on the approach that they use, they may or may not need a chest tube after surgery, so be aware and prepared for that. And then afterwards, they're going to have a slow wean after surgery with respiratory support. Cough, turn, and deep breathing is extremely important, as well as incentive spirometry, trying to prevent any pneumonias or respiratory side effects. Community-based care, so we do need to help the patient and the family. And so if they need any adaptive equipment, then we need to order that and work with PT, OT, and speech to get that. They need to be informed about the multiple drugs that they might be on with this one, as well as signs of exacerbation or signs of medication complications. We need to teach about avoiding extreme heat, crowds, overeating, changes in sleep habits, or emotional extremes, as that might trigger MG. We can direct them onto myasthenia gravis foundation, which is an excellent support for these patients and their family members. Guillain-Barré syndrome, so GBS, is caused by an immune response attacking the myelin of the peripheral nervous system, and this leads into a progressive motor weakness. Generally speaking, this is an ascending weakness, although it can be descending on rare occasions, but it's ascending generally speaking and can cause some paralysis. So patients with this, if it ascends high enough, they might need mechanical ventilation with this, and they might have some sensory abnormalities with this, so itching or crawling of their skin. This can last short term for a couple of weeks, or long term up to a couple of years. Causes are unclear, but usually there's an acute illness prior to this or trauma right before this. Subjectively, so the chronological order of this is very important, realizing that there's probably a leading factor, like we said before, of some kind of infection or trauma, and then you're going to see that it's ascending. So it usually starts in the feet, where they get muscle weakness, pain, or tingling, and some pain and pallor and paresthesia, and that's going to ascend up their legs. So things we want to do, of course, is see where this is at, see what kind of signs and symptoms they have, and see how fast this is ascending. So we do want to look at their facial nerves, we want to look at their cough and swallow, because ultimately, if it goes high enough, they will need respiratory support with this one. There's no single test, unfortunately, that we could do with this one. We might do an LP, and that might show some increase in protein. A WBC count might be mildly elevated, especially if they've got an inflammation or an infection. EP studies can demonstrate some myelinating neuropathy, but that takes a while to develop. Electromyography is looking at nerve conduction, and you might see a decrease in the velocity of that nerve conduction. An MRI or CT can be used to look for other causes of motor weakness. So nursing priorities, of course, airway, breathing, circulation is paramount with this one. Impaired mobility, risk for cardiac dysfunction, pain, impaired communication, altered nutrition, and impaired coping are extremely important. With this one, they might have impaired motor neural situations, but generally speaking, they retain their level of consciousness, so they're aware of what's going on with this, even though they can't move and they're having some different sensations. Planning and implementation with this, so often we're talking about plasmapheresis or IVIG. Steroids were used in the past, but they're usually not recommended now, as IVIG and plasmapheresis is more effective. We'll manage the airway, keep the head of the bed up, suction as needed, promoting cough turning, deep breathing, and incentive spirometry as much as possible. We'll monitor ABGs, especially if it gets up to the level of the diaphragm and they're having respiratory complications. Collaborative care. They can have cardiac dysfunction with this because your heart is a muscle, and so we're going to monitor, treat that, watch any hypertension or hypotension with this, and any bradycardia that might occur as well. We do want to have PT/OT and help with ambulation, position changes, and increase their strength as much as possible. Dietary management, trying to get them as high quality of food as we can so that they can heal and recover. Prevent any DVTs using prophylaxis such as Lovenox or sequential compression devices. Manage pain with some opioids, and then promote communication and psychosocial support as much as possible. Community care-wise, severity is highly variable. Some people, it only stays in their feet. They get some weird tingling and it goes away. Some people have the need to be intubated and cared for a long term. So, case management is paramount with this one, including the family. And then we can refer them on to the Guillain-Barré Syndrome Foundation as needed. Trigeminal neuralgia, so this is a disease affecting the fifth cranial nerve, and unfortunately causes a lot of intense unilateral facial spasms and pain. These spasms can be provoked by minimal stimulation, such as a dental procedure, or for an unknown cause. So this can be familial in nature, but it does tend to occur more in patients that are older than 50 years old and more than in women. So, with this, it can be caused by trauma, infection, and it can be a chronic pain syndrome. So, of course, what we're going to manage with this and a priority is pain. And unfortunately, it doesn't respond to narcotics well. So, with that, we're using multimodal pain and discomfort interventions as much as possible. Carbamazepine and baclofen are drugs of choice with this one. And if that is refractory to that, surgical management using microvascular decompression could be an option, but it's not commonly utilized. So that concludes this lecture. If you have any questions in regards to this, please feel free to reach out.